Hey everyone, this is Ryan here, and welcome back to our series on pharmacology. So far we've talked about anesthetics, we've talked about antibiotics, and now in this video we're going to talk about the last of the three A's, analgesics. So analgesics are drugs that are taken to relieve pain, and many of them double as anti-inflammatory agents as well. And we'll talk about that more when we talk about how these drugs actually work. So there are going to be a lot of names in this video again, but a lot less categories to remember than antibiotics, so that's some good news. So with that, let's begin. So the first category of drugs we're going to cover are the NSAIDs, and this is an acronym standing for non-steroidal anti-inflammatory drugs. So it's called non-steroidal because they're not steroids, which is another category of analgesics we're going to cover in this video. They're anti-inflammatory, which means they limit or prevent inflammation. So inflammation is a natural body response, and when acute and short-lived, it can actually be pretty helpful, but as soon as it's chronic and long-lived, it's bad for the body. So we have all these drugs here that can help with that. So there's a lot of information on this slide, but there's only a little bit that I would recommend really knowing well. The first one is aspirin. So aspirin is also can be referred to as acetyl salicylic acid, and ASA for short. So it's also sometimes called a salicylate because of its derivative salicylic acid. So aspirin is a COX-1 and 2 blocker. So it blocks this enzyme called cyclooxygenase, also called COX, and it's non-selective. So it blocks both COX-1 and COX-2. Now it's also irreversible, which means it irreversibly blocks this enzyme from doing its job. So in a sense, it's more potent than some of these others that are reversible. Now I also have GI listed off to the side here because aspirin has been known to impact the GI or gastrointestinal system and can cause an upset stomach and impact it negatively. So ibuprofen is the next one, commercially available as Motrin and Advil, and this is also a COX-1 and 2 blocker, but it's reversible. Now this one I have kidney off to the side, and that's because ibuprofen is tough on the kidney. So there's a theme going on here, and there's one more, and the next slide I'm going to talk about, that impacts another organ system. Now we also have naproxen, commercially available as Aleve, and some of these others, maybe just know the name, know they're an NSAID, but I probably wouldn't know too much else here. Ketorolac is available intravascular, intramuscular, and oral. Indomethacin has been linked to some rare cases of blood dyscrasias. Phenylbutazone, also called Bute for short, is used for animals. Diflunisal has a longer half-life than these other NSAIDs. And then we're left with these two at the bottom, celecoxib and meloxicam, which relatively are newer drugs, and they're selective. They only block COX-2, which, if you're thinking COX-1 and COX-2, cyclooxygenase 2 is kind of the bad enzyme, or the worst of the two enzymes here, because they do serve a normal purpose in the function of the human body, but if we were to block one only, COX-2 would be our pick. So these two are selective as opposed to the rest that are non-selective, and you can get an exam question that straight up asks you which of these are selective COX-2 blockers, and you'd remember these two names here. And meloxicam is commonly prescribed typically for older patients or patients with arthritis, so osteoarthritis, rheumatoid arthritis, people battling chronic pain in their feet, in their knees, in their hips, stuff like that. Meloxicam can help out. All right, so enough about that. Let's talk about acetaminophen, which is commercially available as Tylenol. So Tylenol is an interesting drug, but the most important thing to remember is that acetaminophen is not an NSAID. So I'll say it one more time. Acetaminophen is not a nonsteroidal anti-inflammatory drug, and that's probably the most important thing you need to know about it. So also interesting, its exact mechanism is not really understood. We know it inhibits pain in the central nervous system, and it's especially useful for headaches, which are centrally derived, but we don't know the exact mechanism. That's not important here. And like I told you, I have the organ system on the right here. The liver is impacted by acetaminophen. So in higher doses, it can be hepatotoxic, especially if you're combining it and ingesting it concurrently with alcohol. It can be very damaging to the liver. So to review, aspirin is tough on the GI system, ibuprofen is tough on the kidney, and acetaminophen is tough on the liver. And this is an incredibly important triad of information because the test could easily ask you, like a patient has kidney disease, which of these drugs would you use to manage their pain? And if they have kidney disease, well, you wouldn't want ibuprofen, which negatively impacts the kidney. So pick acetaminophen. Or if a patient has some form of liver disease, then avoid acetaminophen and pick ibuprofen or aspirin. So something like that could definitely appear on the exam. All right, and this is just for reference. Maximum dose per day that you can take ibuprofen would be 3.2 grams in a day, and acetaminophen would be up to 4 grams in a day. All right, so this slide is probably the most important slide we've talked about so far, if not the most important slide in this entire video, and that's the therapeutic effects of aspirin. So first, it's an analgesic, of course, because that's what this whole video is about. So how is it an analgesic? Well, we've already talked about it inhibits cyclooxygenase 1 and 2. And by doing that, it inhibits prostaglandin synthesis. So this is crucial to remember, that aspirin and these NSAIDs inhibit prostaglandin synthesis. So I'm going to refer to this pathway here, and we start with phospholipids, which are found in those membranes, and they get converted to arachidonic acid, which gets converted to prostaglandin, which is this pro-inflammatory agent. So if we inhibit prostaglandin synthesis, we can stop or prevent inflammation. So that's how aspirin works. It works by inhibiting number 2 of this pathway here. Now it's anti-inflammatory by the same mechanism, which makes sense. I said it prevents inflammation. It also helps relieve pain by the same mechanism. And it's also antipyretic, which means it's used to treat fevers. And how it does so is it inhibits prostaglandin synthesis. So the same mechanism, but this time specifically in the temperature regulation center of the hypothalamus. So that is pretty important. I would definitely remember that its antipyretic mechanism is specifically inhibiting prostaglandins in the hypothalamus. And lastly, aspirin affects the bleeding time. And so I have this video on the platelet pathway, and aspirin inhibits thromboxane 2 synthesis, which is a branching off point of this pathway here, and thromboxane A2 is critical with platelet activation, but for the board exam, I would know that it inhibits platelet aggregation is the kind of thing they like to ask about. So aspirin can be taken as a baby aspirin every day for heart health. You can also take a higher dose aspirin to help prevent clotting by inhibiting platelet aggregation. All right, so the toxic effects of aspirin, if you take too much or use it too often, can cause occult bleeding from the GI tract, tinnitus, nausea and vomiting, metabolic acidosis, decreased tubular resorption of uric acid, salicylism, delirium, and hyperventilation. So what's important to know from this long list of things? Well, like I said, aspirin impacts the GI system negatively. So the big thing here to remember is that it's toxic for the GI. If you're wondering, salicylism is this toxic condition produced by the excessive intake of salicylic acid, which aspirin is a form of, and it's kind of involving this tinnitus, which is ringing in the ears, and also this nausea and vomiting. But again, GI is the thing I would take away from this slide. All right, so the next category we have NSAIDs so far, we have acetaminophen, and now we have corticosteroids, which is the next big category we're going to talk about. So this name is actually pretty logical. Cortico is referring to the fact that it's produced in the cortex of the adrenal glands, and they are steroids. So they have this 4-ringed steroid skeleton structure molecularly, something that's shared by all of these steroids. So this one, in fact, I think is aldosterone, but we're going to be talking about these corticosteroids here: prednisone, hydrocortisone, triamcinolone, and dexamethasone, and they all end with this "-one" suffix, which if you watch my video on antibiotics, we talked a lot about these like prefixes and suffixes that help us remember drugs in specific categories. So again, this comes in handy. All right, so the therapeutic effects of steroids. So we talked about the NSAIDs blocking number 2 in this pathway, and you probably see where I'm going with this. The analgesic and anti-inflammatory mechanism of steroids is to inhibit this enzyme phospholipase A2, which inhibits arachidonic acid synthesis. So where NSAIDs inhibited number 2, steroids inhibit number 1 of the same pathway. So again, they're doing the same thing, just blocking the pathway at a different point in this biosynthesis. So pretty cool. Alright, so the side or toxic effects of steroids. So they also can contribute to gastric ulcers, interestingly also impacting the GI system. They can cause immunosuppression, so if used chronically or often enough, they can dampen the immune system and the immune response. So for example, taking a lot of steroids can actually wake up a latent tuberculosis infection, or an AIDS patient probably shouldn't be taking steroids because you don't want to dampen the immune system any further. I'm going to skip this next one: osteoporosis, hyperglycemia, redistribution of body fat, all side effects of taking steroids. And then this idea of acute adrenal insufficiency. So I'm actually going to get the pen out here real quick because this is an important topic and something that can appear on the board exam. So I just wanted to mention it briefly. There's this idea called the rule of twos, and that is that adrenal suppression can occur if a patient is taking 20 milligrams of cortisone or its equivalent daily for 2 weeks within 2 years of dental treatment. So 20 milligrams of cortisone or its equivalent for a duration of 2 weeks within 2 years of dental treatment. And a patient following this guideline can experience adrenal suppression, which can be a medical emergency. So this patient would need a supplement dose of steroids prior to dental surgery, for instance. So the rule of twos and these numbers specifically are something I would definitely commit to memory. Could appear on the board exam just asking you what the guidelines are for this specific rule, knowing 20 milligrams, 2 weeks, 2 years. All right, so now our fourth category here is narcotics, also called opioids, these two things being synonyms. So their mechanism of action is they're mu-opioid receptor agonists. So they agonize this receptor in the central nervous system. That's how they relieve pain. So there's a ton of names here. Some of them may sound familiar, and there are only a few I would really remember specific facts about. So morphine, hydrocodone, and oxycodone we're going to talk about in the next slide, so those will come up as being pretty important. OxyContin is the same as oxycodone, except it has this controlled release mechanism, and the CONT matching the name and this mechanism, so that's helpful. Codeine is an important one to remember in that it suppresses the cough reflex, often found in very low doses in cough syrup. So I should have underlined the CO of codeine because it matches CO of cough. Tramadol is similar to codeine. Then we have heroin and some much stronger versions of it. And Demerol is lethal if combined with a monoamine oxidase inhibitor, which is a type of antidepressant. So hydrocodone and oxycodone, like I just said, will appear in this slide, the combination narcotics. So probably the most commonly prescribed narcotics in dentistry to manage only severe pain, and these should be saved for only cases that really, really require them. And this combination is referring to the fact that we have a narcotic being combined with another medication, in this case, acetaminophen, which I have abbreviated as APAP or APAP, which it can be often seen as. So Vicodin is a combination of hydrocodone with acetaminophen. So here we have our narcotic plus APAP. Percocet is oxycodone plus APAP. So I try to remember this because O and P are next to each other in the alphabet, so those two line up, and then we have H and V up here. Now Tylenol, just by itself, is acetaminophen like we talked about, but there are these narcotic forms, Tylenol number 1, number 2, number 3, and number 4, each getting stronger as we go up. So how I remember the doses of this, and these are actually probably important to remember. I definitely memorized these. Tylenol 3 is where I start. So Tylenol 3 has 300 milligrams of acetaminophen and 30 milligrams of codeine. It's kind of like a rule of threes, I guess. We have all these threes here. Now, when we go to a different number of Tylenol, the 300 stays the same. So that actually doesn't change, which is really nice. The 30 milligrams of codeine does change, though. So when we go up from number 3 to number 4, we just double that milligrams of codeine. When we go down, we half it. So we go from 30 to 15, and then we go 15, rounded up to 8. So I always start with Tylenol 3, and then I branch off from there. If they ask for what would be the dosage of this form of Tylenol, could definitely be a question. So hopefully that's a helpful way to help you remember those. All right, so now let's talk about the therapeutic and side effects of morphine. So we have meiosis is the first one, and that is referring to pupil constriction. So that's more of a side effect. The next one is out of it, which is referring to sedation. So if you're using it in the context of dental treatment, could be therapeutic. Respiratory depression. So the respiratory center of the medulla loses sensitivity to carbon dioxide, can lead to respiratory depression, which of course is an extremely toxic side effect of morphine. Next we have pneumonia. So You can actually get this thing called aspiration pneumonia, where you aspirate fluids from the mouth and the stomach due to respiratory depression. So pneumonia can be a result of this toxic side effect and itself be a very toxic side effect. Next we have hypotension, which is a side effect in frequency, which refers to urinary retention and constipation. Next we have nausea and vomiting, and this is because morphine triggers the chemoreceptor trigger zone, or CTZ, of the medulla. So again, we have the medulla being messed with by morphine, so in the case of respiratory depression and nausea and vomiting. So the medulla is an important thing to remember, as morphine is affecting that pretty severely. And last, we have euphoria and dysphoria, which basically means this feeling of happiness and feeling of sadness. So, as I was talking, you may have noticed this awesome acronym, which is so helpful for remembering morphine and all of these narcotics, because the acronym itself is morphine. So if you can write out the word morphine and then remember each of these things, I promise this will be really helpful and probably net you like three questions on the board exam. So I would definitely learn this acronym as I take a drink of water. Okay, sorry about that. And then the toxic effects of an overdose, like I said, would involve respiratory depression, meiosis would probably involved, and also you'd go into a coma. So definitely can be toxic if taken too much. All right, and so this idea of overdose and addiction. So there are all of these drugs here that can help in these situations. I don't think I actually got a question on these, but probably still helpful to know anyway. So naloxone is an inverse agonist and is used in emergency situations. So someone has overdosed, you call 911 and they would deliver naloxone to that patient. Naltrexone and methadone are used to treat addiction. And then also pentazocine, nalbuphine, and buprenorphine are mixed agonist antagonists. That's their specific mechanism of action. All right, and lastly, I wanted to talk about nitrous oxide. So this is the last category of analgesic. So it is technically an analgesic. It provides a mild analgesic effect as an inhalation agent. So it's also, you may have heard it being called laughing gas, and that is nitrous oxide. So in a dental or medical office, the nitrous oxide tank is always blue in color, and right next to it is this oxygen tank, which is always green in color. So blue for nitrous, green for oxygen. So a little bit of history here. Horace Wells was actually the first to use this for an extraction of his own tooth by his assistant. So these three are very important to remember. The sensation before onset of this analgesic effect is tingling, often in like the limbs and fingers. A side effect, or the most common side effect I should say, of nitrous oxide is nausea. And an impact of long-term exposure to nitrous oxide is peripheral neuropathy. So these three things would definitely commit to memory. All right, and lastly, we have these two concepts, which I just wanted to briefly mention. MAC stands for minimum alveolar concentration, and that is the concentration of some gaseous agent in the alveoli of the lungs required to render 50% of patients immobile. And when I say immobile, I mean like general anesthesia. So the MAC of nitrous oxide is 105%. So 105% concentration is impossible. You can't get over 100% of a gas in some X volume. So this makes sense because it's nowhere near as potent as the general some of the other general anesthetics like sevoflurane and stuff. Their MACs are much, much lower because they're much more potent. So nitrous oxide, it's impossible to immobilize 50% of patients with 100% nitrous oxide. You just can't do it. It's not potent enough. But regardless of this, 30% nitrous oxide is a good baseline for children, and like 30 to 50% for adult patients, and then the other percent being oxygen delivered. And then speaking of oxygen, there's this idea called diffusion hypoxia. And that is referring to the fact that the lungs would fill with nitrous oxide if you just turn the machine off. So if you were delivering this inhalation agent to a patient and you're done with your procedure and you just turn the knob and you kill the nitrous would get stuck in their lungs and they would fill with nitrous, and it could cause a big problem. So you always give patients 100% oxygen for about 3 to 5 minutes to basically flush out all the nitrous oxide from their body. It would eventually leave if you didn't do this, but it's much, much safer to do this as a standard. All right, so that's it for this video. I apologize, I know it was pretty long, but hopefully you found it helpful, as a lot of this stuff is important and could very well appear on the Part 2 dental board exam. So again, I hope you found this video helpful. If you did, please leave a like so I know, and subscribe to my channel if you haven't already for more on dental pharmacology and all things dentistry. Thanks so much for watching, guys, and I'll see you all in the next video.